Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. Maybe this has happened to you or someone you know. You experience scary chest pain, shortness of breath, and you're exhausted. You do the right thing. You go to the emergency department. You get a stress test. Maybe you even undergo a cardiac catheterization. And then you hear the words that should be reassuring, but aren't. You hear your arteries are normal. They're clear. So what has happened? We now know that for many people, the problem isn't blocked major arteries. It's something called coronary microvascular disease, a condition affecting the heart's smallest blood vessels. It's often undiagnosed, misunderstood, and can have a significant impact on the quality of life and long-term heart health. I'm joined today by MedStar Health interventional cardiologist Dr. Brian Case at MedStar Southern Maryland Medical Center, who's going to explain how we diagnose and treat heart disease when the angiogram looks normal, but the symptoms don't. I'm your host, Debra Schindler. Dr. Case, thanks for this discussion.
Yeah, absolutely. I'm so happy to be here today, and thank you for the opportunity to really discuss and shine the light on coronary microvascular disease. I think it's very important to have platforms like this to really get the word out about how important it is for patients to be aware of this disease process. So thank you so much.
Right. When most people think of heart disease, they think of fatty plaque and blocked arteries known as obstructive coronary artery disease. How often do you see patients whose angiograms look relatively normal, but whose symptoms are anything but?
Yeah, I can start off with some statistics. For every patient that undergoes the left heart catheterization for chest pain, so typical symptoms, maybe they get a stress test done by their cardiologist, they end up in our procedure room on the cath lab table. Of those patients, 40% will have quote unquote normal coronaries. That means that they'll do the angiography and the big blood vessels in the heart will be wide open and there'll be no evidence of any blockage or anything like that. Studies have now suggested of those 40% of patients that have quote unquote normal coronaries, up to 50% have coronary microvascular disease. So this is more prevalent than what people in the healthcare field may realize. And it's something that you need to think about and look out for because we're seeing it every day in our cath lab for sure.
So how many people then go home with clear arteries, not knowing what happened still, maybe being called psychosomatic or you had a GI issue or something like that?
Yeah. I think, historically, that's what was happening. Patients were being told, oh, your heart's okay. Your symptoms aren't due to your heart. Maybe it's reflux, maybe it's something to do with your lungs, or maybe you're just making it up, right? And they would get that, reassurance from the cardiologist saying everything's okay, look elsewhere. But now, over the last 5 to 10 years, both with clinical data studies and then also new technologies that we have in the cath lab, we're really understanding that a lot of these patients have coronary microvascular disease. We can evaluate for it, we can make a formal diagnosis. And once we've made that formal diagnosis, we can tailor their medications to treat them, to get them feeling as best as possible, to improve their quality of life, and then also to prevent problems down the road as well.
What are the classic symptoms before we get into what the next steps are in diagnosing this?
Yeah, 100%. Patients that suffer from coronary microvascular disease have a lot of the same symptoms that a patient that would have your classic obstructive coronary disease due to a blockage in a large vessel. They have chest pain, typically left-sided, that would radiate down to the arm or the jaw. Historically, it happens with exertion and then relieves with rest. As the disease process progresses, you can also develop that chest pain at rest, which would be concerning. Associated shortness of breath, associated feelings of fatigue, decreased exercise tolerance, associated dizziness or sweating. Those are kind of the typical symptoms for somebody who has heart disease, and you can also have that for coronary microvascular disease as well. What's important about coronary microvascular disease is sometimes the presentation could be atypical. Patients could just feel fatigued, short of breath. Sometimes they could have what they think is like a GI symptom. So what is that? Reflux, heartburn. And that's actually their heart manifesting their symptoms. When you talk about coronary microvascular disease in general, it impacts women 2/3 about a time versus men. So 60% of the time when we make the diagnosis, it's a woman versus a man. And overall, when women have cardiovascular symptoms, they typically have more of those atypical symptoms, like I was talking about, of shortness of breath, fatigue, reflux symptoms. So it's important that if you're having these symptoms, of course, you're getting evaluated by a cardiologist. And then if you are still having these symptoms and you've been told that your coronaries are normal based off of non-invasive testing like a stress test or a cardiac CT, or you've even undergone a cardiac cath and you're told that your coronaries are normal, but you're still having these symptoms, it's important that you become your own advocate and you really take that extra step to see if coronary microvascular dysfunction is a cause for your symptoms.
Now, you mentioned dysfunction. How is that different from, saying, coronary microvascular disease?
Yeah. Thank you for bringing that up. Coronary microvascular disease is an overarching diagnosis for disease in the small blood vessels. When you look at the small blood vessels, they could have something called coronary microvascular dysfunction. What is that? That is disease of the small vessels, where you have plaque buildup within those vessels, you have distortion in the structure of the small vessels, you have inflammation in the small vessels, just like you have with the big vessels, but the small vessels are diseased, and the small vessels are in charge of regulating the flow of blood to the heart muscle. So you can imagine if the small vessels are diseased, they're not regulating the blood as well, and that can cause the symptoms like we were talking about, chest pain, shortness of breath. A good analogy of coronary microvascular dysfunction is when we do an angiography, we're looking at the big blood vessels. We're looking at the highways, right? The major parkways of the heart. But if you think about it, the side streets, the cul-de-sacs, the neighborhood streets can be diseased as well. And could also be contributing to your symptoms. So at an angiography, we see the big vessels, but we're not seeing those small vessels. And if those are diseased, you could have coronary microvascular dysfunction. That being said, sometimes patients may have, normal structure within the small vessels, but they can have something called microvascular spasm. So that's a little bit different. In those patients, the small vessels are spasming, meaning they're constricting episodically. And when they constrict, they're impeding blood flow to the heart. And that is contributing to the symptoms that they're feeling, like chest pain, shortness of breath, things of that nature. We can also make that diagnosis in the cath lab, which I'm sure we'll talk about. What's important about doing this formal diagnosis and kind of teasing this all out is based off the type of coronary microvascular disease a patient has, that really specifies and allows us to tailor the medications to treat the underlying disease process, to make sure we're being as effective as possible with our medical therapy to relieve those symptoms so the patient feels better.
You talked about the large vessels to a highway or a parkway, and we already know that a blockage in one of those could be lethal, could be fatal. Could that also happen in these smaller, tiny vessels? Yeah.
So the short answer is yes. Sometimes patients that have coronary microvascular dysfunction or spasm of the vessels can present with a heart attack. It could look like they're having a heart attack. Chest pain, abnormal EKGs, abnormal blood markers in the blood indicating a heart attack. And then we take them again to the cath lab. The coronaries are normal, meaning the big blood vessels. But then if you make the formal diagnosis of coronary microvascular disease or microvascular spasm, you could treat them like we just talked about, but so they can present as a heart attack. Or if you're just coming as an outpatient and you're having chest pain, making the diagnosis is important because A, it's going to improve your quality of life. You're going to feel better, but then we're going to get you on the important cardiovascular medications to prevent problems in the future. And we know from a lot of clinical trials that having coronary microvascular dysfunction, having spasm, does put you at an increased risk for cardiovascular events in the future. So getting on all these important medications like statins, beta blockers, calcium channel blockers will help prevent problems in the future.
So it's not deadly by itself.
It's not deadly by itself, but identifying this disease process and the associated risk factors and putting patients on modifiable medications will decrease their risk for future events, meaning 10 years down the road, like a stroke, a heart attack, things of that nature.
I suppose because in theory, the smaller vessels having some kind of unhealthy response or producing plaque and having a blockage that could move into a larger vessel and then thereby be fatal?
Yeah. Yeah. 100%. That's a great way of putting it. And a lot of the risk factors that contribute to coronary microvascular dysfunction are the same risk factors that contribute to, major coronary artery disease. So high blood pressure, high cholesterol, diabetes, smoking, obesity, strong family history, renal dysfunction. They impact both the major arteries and the small arteries. So if we could identify that earlier and get patients on the proper medications, that's going to prevent, problems down the road.
Now, you've already mentioned the cardiac catheterization lab, which is where you would diagnose this. So a patient would come in with heart failure symptoms. You put a cath in them for diagnostics, and then you see that their vessels are clear. Do you automatically think small vessels?
Yeah. No, that's a great question. Let's take one step back before we talk about in the cath lab. To evaluate for coronary microvascular disease, you could do it two ways. You could do it non-invasively, meaning like testing in the office or the cath lab. The non-invasive ways of doing it are doing a modified stress test.
Why would you do it in the office?
Yeah, that's a great question. So
that's a non-emergency situation then.
Yeah. This is in regards to somebody who's having stable symptoms, chest pain. When you're evaluating a patient for coronary microvascular dysfunction, there's two ways you can do it. You could do it in the office, non-invasively. Historically, patients and physicians were going that route because A, there was not the technology in the cath lab to evaluate for it, and B, it's a safe, non-invasive way of doing it, meaning you don't have to undergo a procedure. And the way that they were evaluating for that was either doing a modified stress test, doing a PET scan, which is not readily available for most patients, or doing a cardiac MRI. The diagnostic yield for looking for coronary microvascular dysfunction is pretty good with the non-invasive testing. But the issue with the non-invasive testing is you're unable to evaluate for spasm. Like you can't do that with non-invasive testing. If you do the full coronary functional testing in the cath lab, then you can evaluate for both coronary microvascular dysfunction and the spasm. If a patient is in the cath lab and we've done the diagnostic angiography and that is normal for the major vessels, you're 100% correct. I'm thinking about coronary microvascular disease right away. And the evidence shows that you can 100% move forward and do the evaluation right away. So, and it adds about 10 minutes more to our procedure. We don't need to modify it all. We do it all through the wrist like we do for our diagnostic caths in general. What we do is we give a medication called acetylcholine. This is for the spasm. It's administered at 3 different doses. And we look for 3 things. We look for symptoms.
That's through an IV?
Through actually the catheter that's in the patient's heart.
Oh, okay. And the patient is in a twilight? Or?
Yeah, patient's in a twilight. We call it moderate sedation. I call it la la land.
Right.
But they're not completely under because I want to be able to talk to them and see how they're feeling and how they're reacting to the medication.
Okay.
So yeah, we give the medication, acetylcholine, through the catheter down their heart. And then we look for 3 things. We look for symptoms. Are you having the chest pain that you've been suffering from for so long? We look for EKG changes. Are there changes on the EKG that suggests that something is happening in the microvasculature? And then the last thing we do is we look for evidence of spasm. All right. And the way that we look for that is we do another angiography and we look to see if the big vessels are constricting because they can constrict themselves. Or is there slow flow down the artery along with chest pain and EKG changes that would be suggestive of the small vessels occluding as well? So we can objectively make that diagnosis on the table, real time, that a patient might have spasm. If we do all that, there's no evidence of spasm, then we do the second part of the test, which is evaluating for coronary microvascular dysfunction, which is disease of the small vessels like we were talking about before. The way we do that is we put a small wire down the main artery of the heart, and then we measure flow
through the wrist.
Through the wrist, yeah, the same thing, same procedure, diagnostic through the wrist. We put the wire down the main artery of the heart. We measure flow at rest, and then we measure flow under stress, and we give a medication in the cath lab to measure that. And then we have a technology in the cath lab that does all of the analysis and then gives us objective data to make the formal diagnosis of coronary microvascular dysfunction. Again, This can be done on the cath lab table at the same time as the diagnostic left heart cath. It adds about 10 minutes of extra procedure time, minimal increase in contrast use. The most importantly, it's super, super safe. The risk for any major complication is less than 0.5%. So we can all do this quickly and safely in the cath lab. It provides dramatic impact on the patient because we can make these additional diagnoses that can have a big impact on their quality of life.
Because all cath labs are not alike, is it appropriate for someone to go and ask, do you do the additional testing for CMD?
Yeah, no, 100%. I think it would be important to ask your local cardiologist, your local interventional cardiologist, hey, are you routinely looking for coronary microvascular dysfunction? Are you doing coronary functional testing in your lab? Do you feel comfortable doing it? Do you feel comfortable interpreting the results and managing afterwards? If you're getting a yes, then yeah, go ahead and get it done there. If you're getting a no, or you don't feel great with the response, then, look to your neighboring cities or states and really try to find that provider that can really help you make the formal diagnosis.
You mentioned already that coronary microvascular disease disproportionately affects women. Why is this? And how does this help explain why so many women are told their symptoms are maybe atypical or dismissed altogether?
Yeah, that's a great question. And again, so 2/3 of the time it's women, younger women. The thought process behind why it impacts women more than men is multifactorial. The main reason is the thought of just the changes in hormones in women and subsequently having an impact on the release of certain particles within the heart that impact the dilation and constriction of the blood vessels. That's kind of a short way of putting it. In addition, there's thought that the hormones impact overall inflammation in women and puts them at an increased risk for coronary microvascular disease as compared to men. But the second part of your question is the most important part. So much data has come out that women suffer from coronary artery disease in general, ischemic heart disease, equal to men, but there's always a delay in recognition and treatment for women as compared to men across the board. For coronary artery disease, for women who are having heart attacks in the ER, sometimes their symptoms could be atypical and there's a delay to recognition that they're truly having a heart attack, and then subsequently a delay for treatment. And then for CMD as well, they're told that their symptoms are not related to their heart, and unfortunately they can go on for 1 to 2 years suffering from these symptoms that really could be really debilitating for them. We actually did our own retrospective analysis of our patients that were diagnosed with coronary microvascular dysfunction, and we found that their clinical course is a long one. They usually, on average, 1.5 to 2 years of suffering with their symptoms before they were formally diagnosed with CMD, coronary microvascular dysfunction. And, that's
a long time.
It's a long time.
That's a very long time.
Yeah. It's not just dealing with these symptoms. On average, these patients had multiple presentations to the ER, multiple outpatient stress tests and echocardiograms done. Even some patients had multiple left heart caths done. And again, they were told that their big arteries were normal. And the whole time it was the small vessels that were causing the issue.
I mean, what took so long to recognize it?
I hate to say it, but I think that might have played a part. Like you said at the beginning, it's all in your head type thing. Mm-hmm. Before we've really got a good understanding of coronary microvascular dysfunction, 10, 20 years ago, they used to call it syndrome X, which is now just not something that's used in, the medical field anymore. You have to take these patients seriously. You have to take your symptoms seriously. If you're really suffering from these symptoms, and you're not getting the answers you need, seek additional second opinion. We're here to help you.
I imagine that's very scary for someone who's going through that and then go and they get checked out and they can't find anything. How frustrating is that?
Yeah, I see it all the time. Patients develop distrust to the healthcare system, right? They've gone to 3 or 4 different cardiologists and they're just looking for answers or looking for a cause for their symptoms or looking for a treatment. And they're being told over and over, oh, it's nothing. Oh, it's nothing. Like you said, like it's all in your head.
But you said it was an additional 10 minutes in the cath lab to find that. Is it more expensive? I mean, what would prevent someone from just taking that natural next step to check for microvascular coronary dysfunction?
Yeah, there's a lot of reasons for that. One is just the overall awareness for coronary microvascular disease and CMD within the cardiology world needs to improve. It's gotten much better over the last 5 years, and more centers and sites are doing coronary functional testing to evaluate for these patients, but not nearly as much as we need or should have of interventional cardiologists looking for this disease process. The second one is this perceived notion from interventional cardiologists that it takes a lot of time and it's risky to do this procedure. But like I just said, and this is based off our data, it adds about 10 minutes extra to our procedure. So really not long at all. And no increased risk for complications or anything like that. Minimal increase of contrast use, very, very minimal exposure to additional radiation. And then we've done over 500 patients here at MedStar, between MedStar Washington Hospital Center and MedStar Southern Maryland Hospital. And we haven't had one single complication for many of our patients. And then the third one is cost. This does require some technology in the cath lab. In my mind, the cost is not that much. And I'll tell you why. You have these patients coming in over and over to the ER with chest pain, shortness of breath, and you can just think about the healthcare costs that brings to the healthcare system. And then repeated tests over and over, being told again and again it's normal. And some patients even undergoing multiple left heart caths and being told over and over that things are normal. So there's so much cost going into this repeated testing that you could avoid if you could just make that diagnosis up front. And then more importantly, like we've been talking about, patients are suffering years with these symptoms, and it's really impacting their quality of life. And to have that much of a dramatic impact and make a formal diagnosis, tell the patient, hey, it's not all in your head, you're not quote unquote crazy. There is a cost for your symptoms, and we can put you on medications to make you feel better. Doesn't matter how much anything costs. You can have such a dramatic impact on your patients that way.
Yeah, so that was my next question. You do the extra 10 minutes of testing in the lab and you make a diagnosis. What then is the treatment? Is there medicine that they would be prescribed anyway if the angiogram showed clear vessels, but you're having these symptoms?
Yeah, that's a great question. I'm glad you brought that up, because another criticism about evaluating for coronary microvascular dysfunction that we hear sometimes from cardiologists is why do all this? Because at the end of the day, you're going to put them on either a beta blocker or a calcium channel blocker.
Even if the angiogram is clean.
Yeah, clear. And why don't you just put them on one of those meds, and why to go through this whole procedure? The reason is when you do the full coronary functional testing and you really tease out coronary microvascular dysfunction versus spasm versus sometimes patients having both, then you really tailor your medication to specifically what is going on in the microvasculature. If it's coronary microvascular dysfunction, the first line therapy is going to be beta blocker plus or minus some other medications. There's a nice list that we have. If it's spasm, it's actually going to be calcium channel blockers that you're going to be prescribing for those patients, not the beta blocker.
Which is not a default treatment plan if you didn't have that diagnosis.
Right, exactly. And sometimes beta blockers can make spasm worse. Right. Oh. So knowing the difference is important, and doing the extra step in the cath lab. There's a series of other medications that we can try on patients that have coronary microvascular dysfunction or spasm, and knowing what you're dealing with makes that kind of trial and error of those different medications with the patient much easier. Really pinpoints down that kind of tailor therapy specifically for each patient that you're dealing with that's suffering from microvascular disease.
Now, if there was a blockage and you stented that blockage, that's a permanent fix. Is there a more permanent fix other than medications if these blockages are in the small vessels?
Yeah, no, that's another great question. At the moment, in 2026, medications is all we really have to treat coronary microvascular dysfunction.
Could it go away by itself?
Usually the remodeling that we see with coronary microvascular dysfunction does not fully reverse, but we do know if you stop smoking, get your blood pressure controlled, lower your cholesterol, that we can halt the progression and have patients feel better and get in a good, normal, steady state where you don't have symptoms. In the future, there are new devices that are being evaluated that could be implanted in the heart to help relieve the symptoms related to coronary microvascular dysfunction. The one that's most promising right now is the coronary sinus reducer. I don't want to get too technical about it, but it's a device that's implanted into the venous side of the heart, and it changes the hemodynamics and the pressures in the heart, and it will hopefully reduce the magnitude of, in lack of a better term, congestion in the heart and help relieve the symptoms related to coronary microvascular dysfunction. This is currently being evaluated in a cardiovascular clinical trial. MedStar Washington Hospital Center with Dr. Haider Hashem are a site, and we're currently enrolling patients in that trial to see if the coronary sinus reducer could be impactful for CMD patients. So we're hopeful. We're hopeful in the next few years that there might be a device that's out there to also help treat these patients that are really suffering, even despite medications.
Are there any side effects that would prohibit a patient from wanting to be on a beta blocker or a calcium channel blocker or an ACE inhibitor that would, maybe they say, I don't want to take that forever. I'm not going to take this now. Now that I know it's a small vessel blockage and I'm not going to die, are they okay to do that?
Yeah. So the contraindications to those medications, beta blockers and calcium channel blockers lower your heart rate, and they also lowers your blood pressure a little bit. So of course, if your heart rate is low at baseline or your blood pressure is low at baseline, you don't want to go on these therapies because it might lower it too much and cause you to feel dizzy or maybe even passing out. And we obviously don't want that. So it's okay to not be on these medications. It's okay not to be on it. And again, there's other medications that we could place patients on. For example, long-acting nitrates like Mdor, or a medication called Renexa, ranolazine, that also have impact on the microvasculature, but does not have any major impact on the heart rate or the blood pressure. So we do have options. We have tools in our toolbox from a medication standpoint to really treat patients with CMD if a beta blocker or calcium channel blocker isn't an option.
Well, there's also emerging interest in metabolic therapies, including GLP-1 medications for protecting microvascular health. How do you see that fitting into the future of care?
Yeah, this is an area of interest for me personally. I really do believe that the GLP-1s will play a big part in managing patients with coronary microvascular dysfunction. As we've been discussing, the risk factors for CMD are high blood pressure, high cholesterol, diabetes, obesity, and the GLP-1s, target all four of those things. So you would think that impacting cardiometabolism along with some impact on inflammation has to have some sort of positive impact on the microvasculature as well. Mm-hmm. It just has to. Mm-hmm. But I'm just speculating all this, and the only reason I am is because we don't really know yet, meaning we don't have strong randomized controlled trials really demonstrating that GLP-1s have a direct impact on the microvasculature in the heart. But that's something that here at MedStar that we want to pursue in the future to really see that link and that added benefit of the GLP-1s. We do know that GLP-1s are very beneficial, impactful for patients with established coronary artery disease, like your true blockages in the big vessels who have been stented or have come in with a heart attack and had a stent. So if you're listening to this podcast and you've had, a heart attack or you've had a stent, you may already qualify for a GLP-1, and again, be your own advocate, talk to your cardiologist about getting on these therapies because they are very impactful for just cardiac health in general. And I'm very excited to see how it could impact CMD patients as well.
Are there certain patients who are more likely to develop CMD? You mentioned women, especially postmenopausal, patients with diabetes or high blood pressure. Who else?
I think what we're now realizing with CMD is an overlap with other cardiovascular disease processes, meaning a patient might be diagnosed with something called stress-induced cardiomyopathy, also known as Takotsubo, or they might be diagnosed with heart failure preserved ejection fraction, also known as HFpEF. And what we're realizing is there's an overlap between patients that have Takotsubo, stress-induced cardiomyopathy, and HFpEF, and coronary microvascular disease.
Can you explain what they are briefly?
Yeah. So stress-induced cardiomyopathy, Takotsubo, is a patient acutely comes in with chest pain, shortness of breath. They have normal coronaries, meaning no blockage in the big arteries. But then we look at the heart's function and it's abnormal, but it's abnormal in a certain pattern and way that is consistent with stress-induced cardiomyopathy. So the heart's under stress and it becomes weak in a certain manner is a clinical diagnosis that we call stress-induced cardiomyopathy. Mm-hmm. It's, again, seen more common in women, younger women, and it does have an overall good prognosis with medications. But what we realize is a lot of these patients also have coronary microvascular dysfunction as well. Heart failure with preserved ejection fraction is patients who have heart failure symptoms, so shortness of breath, swelling in their legs, swelling in their stomach, fluid around their lungs, so congestive heart failure, but the actual heart function is normal. When you think about heart failure, you typically think about the heart being weak, but heart failure with preserved ejection fraction, the heart function is normal, but the heart itself is stiff. And that stiffness gives you the signs and symptoms of heart failure, that kind of HFpEF picture. Mm-hmm. And with those patients, a lot of them have high blood pressure, have diabetes, or overweight. And again, we're seeing an overlap between HFpEF and CMD as well. And then I think the last thing quickly to talk about, kind of the overlap that we're finding out a lot at MedStar, is the overlap between patients with cancer history, oncology patients that have undergone treatment for their cancer of any sort. And sometimes the chemotherapy, the radiation, there's a lot of newer medications within oncology that they can have an impact on the heart. We call it cardio-oncology in the cardiology world. And we're finding that a lot of these patients are also having microvascular disease as well, specifically like coronary microvascular dysfunction and also spasm.
That have come about as a result of the chemo, or that it's just being discovered because of their other health concerns?
Yeah, both actually. A lot of it due to the chemo that they're getting, and then a lot of it due to their other health concerns that they're dealing with. And they're having chest pain, they're having shortness of breath, and we can make the diagnosis for those patients and help relieve their symptoms because they're already, of course, dealing with so much with that oncology diagnosis that we can help them figure out the cardiac side of things as well.
When somebody gets that diagnosis, what's generally their biggest concern? Do they ask questions, and what are those questions?
Yeah. Honestly, the biggest thing we see is relief in the patient's face. It's very rewarding because they realize I'm not crazy. Like
I'm not having the big one.
Yeah, and not having the big one. And then my symptoms are real. It's due to coronary microvascular dysfunction. I think the biggest question is always like, am I at risk for a problem in the future? And like we talked about, I always just say, if you take the medications, you're staying on top of control your blood pressure and other risk factors, there's no reason why you'll be at any increased risk for a heart attack in the future, like any other patient. And then the second thing is, how do we treat this? Am my symptoms going to go away? I like to reassure them that there's a series of medications that we're going to try for you, and we're going to work on really relieving your symptoms completely to get you feeling, as best as possible. Those are probably the two biggest questions I hear.
If a person has experienced a CMD, is it usually a reoccurring condition? Will they have it again?
Yeah, I would say if somebody has CMD, the symptoms are going to be present, and it's our job as a physician to get them on the proper medication to really hopefully get rid of their symptoms or dramatically minimize the intensity or the frequency of the symptoms they're having. That's our goal. Again, sometimes it's a little bit of trial of medications, but overall, we can get a patient in a good spot where they're feeling much better on the medication. Another big thing for CMD patients is something called cardiac rehab. Think of it as like physical therapy of the heart, where patients go to a physical therapy rehab center and they exercise on bikes and treadmills, rowers, being monitored by their heart rate, their rhythm, their blood pressure. Doing cardiac rehab on top of the medications has an even better dramatic impact on CMD patients as well.
If a person has been dismissed from having a heart attack, what should they ask for if they want to further their testing and say, I think I might have microvascular coronary dysfunction?
I think you need to take your symptoms seriously and be your own advocate. There are physicians out in the community who understand coronary microvascular disease and can help you. There's something called the Microvascular Network, and this could be easily Googled. It is a network of physicians throughout the United States, actually in Canada as well, of physicians who are performing coronary microvascular testing. And we even have a map on the website for each state of providers who are doing this testing. So if you're out there and you're having your symptoms and you're just not getting the answer that you need, be your own advocate. Go seek that second opinion from an expert who really knows about coronary microvascular disease. Be your own advocate and get evaluated and get the answers that you deserve. And, here at MedStar, we're here for you, where we can, evaluate you, make the formal diagnosis, and subsequently treat you if you're suffering from these symptoms.
Well, thank you so much, Dr. Case.
Yeah, my pleasure. Thank you so much for the opportunity. This has been great to really discuss something that's a passion of mine. So I really appreciate it.
I've been talking with Dr. Brian Case at MedStar Southern Maryland Medical Center on coronary microvascular disease. Thank you again for sharing your expertise with us here on MedStar Health DocTalk. If you'd like more information on coronary microvascular disease, go to medstarhealth.org/MHVI. Or for an appointment with Dr. Case, call 301-877-5677. To comment on this podcast or recommend a topic for another episode of Doc Talk, send an email to doctalk@medstar.net.